Our next presenters are going to talk to us about negative pressure wound therapy. I'd invite them to please come forward. It'll be led by Dr. Robert Kirsner. He's the chairman and professor of dermatology and Philip Frost Department of Dermatology and Cutaneous Surgery at the University of Miami Miller School of Medicine. He's a researcher, teacher, clinician, and has more than 475 articles to his credit. And he is joined by Kristi Huebner, who holds a Master of Science in Nursing Leadership, and she's been with Smith Nephew Wound Management for the past 13 years, who are the sponsors of this session. Welcome, Kristi. Welcome, Dr. Kirsner.
All right, well, welcome everyone, and thanks so much for being here. We really appreciate your time today. Again, my name's Kristi Huebner, and we're honored to have you here to really go through some really exciting new data and information that we believe really changes the game with negative pressure wound therapy. And so you just heard the bios for myself and Dr. Kirsner. We're very honored to have Dr. Kirsner with us here today to present his data. And I hope that you find after the end of the program that this changes your mindset and how you might consider using single patient use negative pressure wound therapy in the future. So as far as the topics for today, we're going to review a number of things. So we're going to go through the PICO 7 product itself. We will do an overview of some of the challenges of managing lower extremity ulcers and so forth. And then, of course, Dr. Kirsner is going to go through his research and newly published paper that goes through really the outcomes that are associated with the difference in the outcomes with PICO single-use negative pressure compared to traditional negative pressure in lower extremity ulcers. And then we'll review some of the clinical cases from this study as well. And then lastly, we'll also talk a bit about some new mechanism of action evidence that's just recently been released as well. So to kind of get things started, hopefully everybody's had their dinner by now, or breakfast I should say, but I put this slide up here to really kind of make us think back about how we have historically used negative pressure in the past. And so when you look at the wounds up here on the screen, they're the big, the bad, the high draining, the large surface area wounds that are very difficult to manage. And I heard you all just talking about necrotizing fasciitis. Obviously, those are very difficult to manage in itself. And while those aren't the wounds we're going to talk about today, nonetheless, we recognize these are wounds that you treat every day with different modalities like negative pressure. And initially, when we kind of came out with negative pressure years ago, we saved it for the worst of the worst. And so today, where I want you to kind of shift your mind is around the other types of wounds that may not look like this in appearance or size or drainage level, but nonetheless are very difficult to treat, difficult to manage, and difficult to heal. So I kind of just try to open your mind to think about all those other wounds you treat on a daily basis. Now, from a PICO perspective, so PICO 7 is our newest product in the PICO family. And ultimately, when you consider how it was designed and why it was designed, it was really the intent to bring negative pressure to a broader group of patients in a simpler way, in a cost-effective way, with equivalent clinical outcomes. So if you consider, a number of your patients probably use a traditional device today because they need it. However, it may be a bit cumbersome depending on what care setting they're in, if they still need to go back to work, things of that nature. And so PICO was really designed to be this discrete device that could easily fit into a pocket and allow a patient to go back to their activities of daily living with minimal interruption. Now, when you consider how PICO was designed, and you'll notice I have a picture of the dressing up first and not the pump. The reason that is the innovation in PICO, for those of you less familiar with the product, is really in the dressing itself. So the dressing is composed of 4 distinct layers. And the first layer is the silicone wound contact layer. So that's what goes down against the patient's skin, easy to apply, easy to reposition, and less painful on removal as well. And then the second layer is what we call the airlock technology layer. And this is the layer that delivers negative pressure equally across the entire surface area of the dressing. The next layer up is called the superabsorbent layer. So as fluid moves up through the dressing, it moves into the third layer, and there it's locked in. And at that point, the fourth layer, which has a high moisture vapor transmission rate, allows for about 80% of the water vapor to evaporate off the top of the dressing. So it's a continual process of absorption and then evaporation of the water, or the water vapor rather, from the exudate. Now from the outside, it's waterproof and bacteria-proof. So patients can potentially shower. We don't recommend that they bathe or submerge, but they certainly can get it wet without concern. So that's how PICO is able to function without the need for a canister, is that continual process of absorption and then evaporation. Now, when you look at the pump itself, so the pump is very simplistic in nature, and it was designed to really just have one button to play and pause. And some new updates related to the PICO 7 pump is that it's about 25% quieter than its predecessor, and it can also manage air leaks much more effectively as well. And the kit itself now comes with a belt clip in every single kit, which, as simple as that sounds, that was a huge customer request because they needed some place to put it. And so we've put that in every kit so they can easily slide it on a belt loop or hook it to a bra strap or whatever is convenient for the patient. So those are some of the key changes, as well as the fact that we included a spot on the back of the pump to write a date. So it's something as simple as that. We know PICO 7 lasts for 7 days, but now you can write the date that it will expire or the date that you've put it on, whichever you prefer. Now, when you consider negative pressure as a whole, usually the first question we get is, well, how does yours compare to theirs? Is it apples to apples, apples to oranges? What is it? How does it work? And how well does it work? So when we look back at the previous independent data that has been published that compares different types of negative pressure wound therapy systems, there were a number of publications done about 5 or 6 years ago independently that compared foam to foam with different types of pumps, that compared foam to gauze with different kinds of pumps, and then mechanical versus traditional as well, which you'll hear a bit more about when Dr. Kirsner speaks. And at the end of the day, although there were multiple different variables of wound fillers, different types of pumps, different pressure settings, the end results were all the same. There was no clinical difference in the outcomes of these patients that were treated with different types of negative pressure. So up until now, we've really kind of considered all things equal when it comes to negative pressure, that negative pressure is negative pressure. And until now, we've thought that. And so at this point, I'm going to hand it over to Dr. Kirsner, and he is going to share his research about why we believe things are not all equal today. Dr. Kirsner.
Well, good morning, everyone. It's a great pleasure to be here today and to follow up on what Kristi was talking about. That is some of our recent research comparing two different types of negative pressure. And just by way of background, I do want to tell you that I participated in the trial that I'm going to share with you. I was the principal investigator, and I'm also telling you this on behalf of Smith Nephew today. As was mentioned earlier, this is my home. It's down south a bit from the University of Miami. This is the center of the University of Miami Medical Campus, which is a quite large medical campus. It's one of the largest medical centers in the United States. And if you look all the way at the very, very, very top of that picture, you can maybe make out the Atlantic Ocean, and then Miami Beach, South Beach, then Biscayne Bay, downtown Miami, and then circled there is the medical center at the University of Miami. And where the arrow is was that previous picture I showed you from the center of the medical complex. And we have a fairly large dermatology department. By dermatology department standards, we have 35 full-time faculty, 24 residents, and about 140 voluntary faculty as well. So that's a little bit about me, but I wanted to now go into talking a little bit about the disease states that we studied in this trial. And we were looking at limb ulcers, lower extremity ulcers, and we're looking at venous leg ulcers and diabetic neuropathic foot ulcers, diseases you're quite familiar with. And they're really important and common diseases. For example, venous leg ulcers, analysis using insurance databases in the United States, both the government insurance, Medicare, and commercial insurances, suggest that over 2 million Americans each year have venous leg ulcers. If you have two people that are comparative, somebody with a venous leg ulcer costs about $6,000 to $7,000 more each year for the care of that venous leg ulcer. And if you multiply the number of patients each year with venous leg ulcers plus that difference, you get to nearly $15 billion in incremental costs associated with venous leg ulcers. With regards to diabetic foot ulcers, we know they're important for a very long time, but over the last decade or so, we've really come to learn the importance of diabetic foot ulcers, because we know that if you have two patients, one with a diabetic foot ulcer and one without, controlling other factors, patients with diabetic foot ulcers are more likely to die during a defined period of time. 5-year data suggests that nearly 45% of patients with diabetic neuropathic foot ulcers die, and that's higher than patients with breast and prostate cancer. So these are important, prevalent, and costly diseases. Now, the standard of care for each, which is compression for venous leg ulcers and for offloading and debridement for diabetic foot ulcers, is critical to the care. But unfortunately, as we published in the New England Journal of Medicine about a year or two ago, it doesn't always work. And if even in the best case scenarios, only a quarter of patients with venous leg ulcers and a third of patients with diabetic foot ulcers fail to heal in 6 months. So there's a significant number of patients that need more than just standard of care. And that's really where some of this adjuvant therapies come in. This is the paper that we're referring to. I'm going to show you the data from. This was just published in Wound Repair and Regeneration, which is the journal for the Wound Healing Society of the United States. And with my co-authors, and it's a prospective randomized controlled clinical trial on the efficacy of a single-use negative pressure wound therapy system to compare to traditional negative pressure wound pressure. And so let me just give you a little background. I told you a little bit about myself, a little bit about the disease states, but let me tell you a little bit about the type of study that was undertaken. And what the type of study that was undertaken is a comparative efficacy study. Okay, oftentimes we see efficacy studies, that's clinical trials, or we see effectiveness studies, that's real life data. But they often study an active versus a placebo. But when you see a patient, you don't walk into the room and say, Mrs. Jones, would you like to have a treatment? Or would you like to have the placebo? No, what you do is you're thinking to yourself, what am I going to do for this person? What therapy am I going to bring to them that's going to be most beneficial? And that's where this idea of a comparative of two active therapies are used. And so it's really a direct comparison of existing healthcare interventions to determine which works best for whom and when, and that's really with the heart of comparative efficacy and comparative effectiveness studies. Later on top of that, down the road, then you could actually add in cost effectiveness or comparative cost efficacy. But first you have to do comparative efficacy, which again, in the clinical trial settings, and comparative effectiveness, which is a real world settings. Now my interest in this dates back about a decade or so. David Armstrong, Bill Marston, Alex Reselman, and myself published this paper in 2012. And this was the first comparative efficacy study to be done for negative pressure wound therapy. This is a trial that I helped design, and this was a study that looked at two different active negative pressure systems, a traditional negative pressure system and a mechanical negative pressure system. And what we found was that basically we studied them to see if there was a difference, okay? So that type of study where you look if there's any difference and you try to answer the question, are these two equal? Not is one better than other, but are they equal, is called the non-inferiority study. Non-inferiority. Are they equal? There may be benefits to one or the other than the clinical outcome, but are they equal from a clinical standpoint? And in this case, we used a traditional negative pressure device, and we used the SNAP device in the study. And this was a study of 65 patients. It was a 16-week study. 53 patients completed the study, and for the first 4 weeks, and then 33 patients completed the full study of 16 weeks healing. And over this time period with this number of patients, we found that there was no difference. There was a non-inferiority of the mechanical device to the traditional device. Okay, non-inferiority. And that's going to become very important as I move on to tell you the rest of the information. Okay, so this led to the study I'm going to share with you now that was just published, in which the aim of this study was to compare this PICO device, which is a single-use negative pressure wound device, with traditional negative pressure wound therapies, okay? And they've been used across clinical settings. I think if I asked you here how many people have used negative pressure, probably 110% of you would raise your hand. So they're used quite a bit. There's excellent clinical evidence for diabetic foot ulcers and less evidence for venous leg ulcers, but I think they're used across the board. And I think we're beginning to look for better ways to deliver negative pressure, okay, or different ways to deliver negative pressure. So this was the design of the study, okay? This was a prospective, multi-center, phase 4, that means the products are already approved, open label trial, meaning that when you put it on, patients knew what they were getting because they could see the products. And I apologize for the color scheme, but essentially what it says is that a bunch of patients were screened. Of a bunch of patients that were screened, which was over 200, about 53 didn't meet exclusion criteria. These were venous leg ulcers and diabetic foot ulcers. And then they were randomized to what we call an intent-to-treat population, intent-to-treat. And 161 patients were randomized to intent-to-treat. Now, normally, intent-to-treat is what you're looking for in superiority analysis. Okay? So anybody who might get the therapy, whether they got it effectively or not, or whether they dropped out or not, you analyze the whole group. That's the gold standard. But when you're doing a non-inferiority study, you really want to study who actually got the treatment. Because it's unfair to say one thing's non-inferior to another when half the people never got the treatment. So in this type of analysis, from a statistical standpoint, you actually want to look at the per protocol group. Because you don't want to say, well, one's not better than the other, they're equal, there's non-inferiority, but a bunch of them didn't get the therapy. In that group, there was about 115 patients that were analyzed for the per protocol analysis. So there's two different groups I'm going to share with you. The intent to treat population, which is a population you look for superiority, and then there's the per protocol population, is the group you look for when you're looking at non-inferiority, okay? And initially, because of this other data, the thought was, well, the single-use negative pressure is really great. People are going to love it, but there's probably no difference in negative pressure, and we were looking for non-inferiority. Okay? Now, what did we compare the single-use negative pressure to? To a variety of traditional negative pressure devices. So it just didn't prove one. There's a bunch of negative pressure devices listed here that were used in the control group as the traditional negative pressure. And the study was a shorter study than that earlier publication. This study went on for 12 weeks as opposed to the 16 weeks I had showed you. The venous leg ulcers were traditional size venous leg ulcers ranging from 2 to 36 centimeters, and the diabetic foot ulcers were typical diabetic foot ulcers ranging from about 0.5 to 10 centimeters squared. Okay, these were conducted at 16 sites in the U.S. and in Canada, and it was on clinicaltrials.gov, and the details beyond the publication are there as well. Okay, so It turns out this number of patients, the 161 patients that were enrolled, was more, 3 times more than that other publication I was telling you about, the 53 patients in the SNAP trial. There are more patients completed this trial, 115 compared to 33. There were more sites, so when you have more sites, it leads to greater generalizability of the results, 16 versus 12 sites. And actually, the data I'm going to show you is a shorter study. Many people are impatient. We don't want to wait 16, 20, 26 weeks for results. This is a 12-week study, which is considered the kind of the typical time frame of a modern outcome study. Okay, this is a chart showing the demographic characteristics of the two groups. The PICO group and the traditional negative pressure group, again, looking at age, their BMI and the gender distribution. And what you can see is that there is no statistical differences in the characteristics of this of these groups. Okay. Overall, if you look at the full population of patients, you see that the mean age for this 161 patients was 61.5 years. About 2/3 were male. The BMI was about 34. The mean duration was about 6 months or 27 weeks. About 2/3 of the patients had venous leg ulcers. 1/3 had diabetic foot ulcers. And then we looked at various wound size characteristics. We looked at wound area, which on average was 6.6 centimeters. We looked at wound depth, which is 3.2 millimeters. And then we looked at volume, the combination of the area and the depth, and it was 0.3 centimeters cubed. So here's the data. Here's the data. And again, I want to show you this data in 2 different ways. The first data is per protocol population, the PP population. That's the population that we're looking at non-inferiority. It's a smaller population because these people actually got the treatment. And then we looked at the intent to treat population, where we may glean some information about superiority. The primary endpoint was the change in wound size, but I'll also share with you healing data in a second. And in the red bar is the PICO group, and in the gray bar is the traditional negative pressure. And when you set up a non-inferiority study, you have to say, what does non-inferiority mean? And in this case, we said if there was 12%, 12.5% difference between wound size reduction between the two groups, they were considered non-inferior. So before you even start the study, you define what non-inferiority means. But when you look at the difference and you look at the per protocol difference, there was actually a 27% greater decrease in wound area when you got the PICO device compared to the negative pressure device. And if you look at the intent to treat group, the difference was even greater. This was about a 39% difference. So both of these groups were bigger than 12.5%. So it turns out that there wasn't non-inferiority. They weren't the same. They were different. They exceeded the non-inferiority criteria. They exceeded the non-inferiority criteria. Now then, we also looked at healing, and this is a survival curve or a Kaplan-Meier curve. It looks at the number of wounds that survive. You don't want the wound to survive. You want the wound to not survive, unlike cancer patients, which you want them to survive. So the less survival of the wound, the better. And this is the data. And what this shows you, looking at the PICO group versus the negative pressure group, and looking at complete wound closure, it was observed in 45% of the patients who got PICO and 22% of the patients who got traditional negative pressure wound therapy. So there was a significantly greater number of patients that healed when they got PICO compared to those that got traditional negative pressure, okay? So then we decided to look at other endpoints. We didn't look just at the area, which was the primary endpoint. We also looked at things like depth and volume. So here you can see, again, we predetermined the non-inferiority to be 12.5%. And once again, whether it's the per protocol or population, that's people that actually use the product the right way, There was a 30.8% difference in wound depth reduction with the PICO compared to traditional, and the 32% difference in wound depth reduction when you looked at the intent to treat population. So again, exceeded non-inferiority. These two treatments are not the same. They're not the same. And then if you look at wound volume, again, you see similar differences. A dramatic difference in wound volume with the use of the PICO, 79.5%, and over a 90% difference in the intent to treat population compared to traditional negative wound therapy. So again, exceeding non-inferiority. So whether it's wound area reduction, wound depth, or wound volume, the two different treatments are non-inferior, not the same, not the same, okay? They're not non-inferior. So this was surprising. This was quite surprising. And in fact, because you saw non-inferiority in the intent to treat population, the conclusion is that one product is superior to the other. The PICO, in this study, the PICO device was superior to traditional negative pressure wound therapy, which was very interesting, actually unexpected, because as we said, we assumed negative pressure was all the same, and we thought that went into it, well, it's probably going to be non-inferior, and that maybe patients would like the PICO device better, okay? And we thought that was going to be the outcome as this trial enrolled, but it turned out that that's not what we found. We found that people like the PICO device better, and this is their impact on quality of life, looking at overall satisfaction, the desire to use the product again, or comfortability. All of those favored in a statistically significant way the PICO device. And when we looked at interferes with mobility, reduced activity, and disrupts sleep, all of those also favored the PICO device. So while we saw this, we also saw that there was a difference in clinical outcomes: complete healing, area reduction, volume reduction, and depth reduction, and suggesting that something is different about this device than other negative pressure devices, which is quite interesting, quite intriguing, and unexpected. So I'm going to just summarize what I told you, and then I'm going to bring back Kristi, who's going to share with you some information about how Smith Nephew is now going on to explore why. So we saw this in a well-done, randomized controlled trial, but why is that? Why did that happen? What's going on? What's the process? And it lends insight not only to negative pressure, but to wound healing in general. So I'll stop here and just conclude by saying in this prospective phase 4 multi-center randomized study of this PICO single negative pressure wound healing device versus negative pressure, we didn't see non-inferiority. What we saw was superiority. There was superiority in wound closure, area, depth, and volume over 12 weeks. And patients preferred this. It performed well. Patients liked this device. They found it to be easier to use, more comfortable, overall satisfaction, didn't disrupt their daily living, like sleeping in this. So it tells us two things. One is that in real-life clinical, when you're coming to the decision point to pick a negative pressure device, you should consider this because of this data we presented, both from a patient-oriented data and outcomes data. And it also will lend us insight in some of the mechanisms of healing that may be important when choosing a negative pressure wound device. So I'm going to stop here and invite Kristi back up to the stage so she can go further. Thank you very much for your attention.
Thank you, Dr. Kirsner. So as he said, the first time we presented this data, which was about a year ago right now, the very first question we got from the audience was, why do you think these results are what they are? And at the time, we didn't have that answer. And so honestly, we could only hypothesize why we might be getting these superior results out of this study. And so ultimately what was done was an experimental study. But before we get into that, I want to share some of the clinical cases from Dr. Kirsner's study, so you can kind of see the progression of these wounds and see things that you want to kind of put in the back of your mind as you hear the rest of this talk, because it will come up again. So what you see up here is several cases of VLUs. So VLUs and DFUs were the two wounds that were treated in the study. And I draw your attention to the progression of all three of these patients, but ultimately look at the peri-wound area. So when you get to the point of the last images, you can see the imprint of the PICO dressing there. And while that might not seem important right now, what we're finding is that's making a significant difference in how these wounds heal. And what we also saw was sort of this rapid epithelialization under PICO. So not necessarily all about contraction. We think a lot about contraction with traditional negative pressure, but in this case, these wounds were epithelializing underneath of PICO. Now, another example, so this was a smaller DFU, plantar aspect of the foot, not large. And some of you in the audience might be thinking, well, I wouldn't use negative pressure on that anyway, because it's tiny, it would be complicated to cut foam and try to get that right, but maybe some of you would. Here you can see the PICO dressing in place. So simple to apply, about as easy to apply as a foam dressing, in all honesty, in that location. And then ultimately, after about 4 weeks of therapy, this patient went on to close. And you all know, any of you treating DFUs in the audience, what looks small is sometimes much larger underneath. So these can be quite complex, even though they appear small. So this is really a fantastic result for a patient like this that could have gone on to have a much more significant wound. Here's another example of a VLU patient treated. A young patient, 47 years old, had this VLU for a number of months and was not progressing, was in compression therapy, but still was not getting over the hump, was entered into the trial, and you can see the PICO dressing in place. You can see that the dressing goes much far beyond where just the wound is, but rather it's covering the wound margin, as well as that peri-wound area. And again, after about 7 weeks of therapy, this patient achieved complete closure. And I draw your attention to that imprint of the dressing so you can kind of see where negative pressure is being delivered. So it's not just about the wound. It's about the edge of the wound, and it's about the peri-wound area as well. So when it came to looking at this patient, again, this was a little bit larger DFU. Again, you can kind of see the dressing in place. You can see what the strike-through looks like on the dressing. Oftentimes we get questions about, how do we know when to change the dressing? And so we watch for the amount of strike-through. And when it gets to about, 65, 70% strike-through, that's when it should be changed. You can see, again, the progression of this wound after 4 weeks of therapy. And then, again, after about 8 weeks of treatment, getting very much smaller. And then at the end of the treatment, 11 weeks, just prior to the end of the study, the patient had closed. So, again, I go back to that initial question about why are we seeing superior results with PICO versus traditional negative pressure? Because we know that traditional negative pressure works, and it works well. So it begs the question, what's happening with PICO that's different versus traditional negative pressure? And one of the key things is the fact that there's this lack of a need for a filler. So in the majority of the wounds treated in this study, which I believe was around 87% of the PICO-treated wounds, did not require the use of a wound filler. And when I say wound filler, I mean something like a black foam or a gauze or something to fill the deficit. Okay, so the majority did not require that. It was simply the PICO dressing that was applied versus the traditional system. So could that be part of it? Is that what's driving part of the difference, is that we're delivering negative pressure to a wider zone of area? Also, this concept of uninterrupted healing. So The fact that you don't need a wound filler dictates the frequency of how often you have to change the dressing. So we know if we put a wound filler in the dressing, with the dressing, you have to change it a couple times a week. If PICO is applied by itself, technically it can go on and be left on for 7 days, depending on exudate levels, which in this study, the average dressing wear time for PICO was almost 7 days, so it was about 6.5 days. So this concept of uninterrupted healing is also part of that. And then lastly is kind of the portability and simplicity that Dr. Kirsner was just talking about. That's what we assumed would make this product more desirable, but it may also have played a part in the clinical outcome as well. So when we look at kind of how the experimental study was designed, it was really, the goal was to replicate something similar to the clinical study, to be able to say, okay, we're comparing traditional negative pressure again to PICO in similar wound types, and again, look at the healing rates, the epithelialization, the differences in granulation tissue, as well as the peri-wound area. Okay, so think back to those images that I showed you and the importance of that peri-wound area. So an experimental study was done late last year, and this was done on pig models. And ultimately, it was attempted to be designed as similar as possible, as you can do on pigs, as the clinical study that Dr. Kirsner just described. And so it was to compare PICO to a traditional device with foam, and it was done over the course of an 18-day period of time. And so traditional dressings were changed every 3 days. The PICO dressing was changed every 6, just to be in concordance with the same timeline as the traditional device. And then they watched and measured different outcomes throughout. So the first one was really looking at that hypothesis of undisturbed healing and what was happening under the PICO dressing that potentially was different than the traditional device. And so again, in the experimental study, it demonstrated a decrease in wound area similar to the clinical study, okay? So we saw this decrease that was very close to what the clinical study was and met statistical significance as well. Now, when you look at the reason why, oftentimes we think, again, it's about contraction, but in this particular nature, it was not about contraction. It was about re-epithelialization underneath the dressing, which is what we were seeing with the PICO-treated wounds, but not necessarily with the traditional treated wounds. And if you think about it, the traditional wounds have a filler in it. So could that potentially be creating some sort of a barrier in these situations where you have more superficial wounds, and so those wounds aren't epithelializing as quickly? So that's certainly a question that still needs to be answered, but that's what this experimental study was telling us. And then another hypothesis is the fact that the PICO dressing is delivering negative pressure beyond just the wound. So typically when we think about negative pressure, we think about cutting foam or piecing gauze or some other sort of filler and just focusing on the wound. But what PICO is doing differently, as I mentioned, is it's delivering that negative pressure to the wound bed, the edge of the wound, and the peri-wound area. So could that be contributing to why we're seeing some of these type of outcomes? Could that be contributing to this reduction of edema that we visually can see in the peri-wound area from where that imprint is? So one of the ways this was investigated was the wounds were actually put under CT scanning for a 24-hour period to look at the displacement of the compressive forces, so to speak. So when you look at the two differences up here on screen, the top is PICO and the bottom is traditional negative pressure, you can kind of see how there's this wider zone in the PICO-treated group. So it goes well beyond the margins of the wound. So it's demonstrating that there are compressive forces that are occurring well beyond just the wound itself. So what does that mean to us? Well, we all know what compression does. It reduces edema. And we know that even in closed surgical incisions, That's one of the key mechanisms of action for why this works on incisions, because it compresses the incision and the tissue around it. So what this showed was ultimately it's doing something similar. And so can that have that type of effect on, say, a chronic wound like a VLU or a DFU? And so again, that's kind of where we're trying to investigate to learn why is that difference so significant. And then, lastly, really is this notion about the ease of use for the patient. So this portability, simplicity with using PICO, we really can't discount that fact, because ultimately, think about it, if it were you and you're trying to go to work every day and you're holding a pump that's around your shoulder and hanging at your waist and you can see the fluid in the tubing, versus something you can hide in your pocket and no one can hear it and no one can see it or even realize that you have it there. So that simplicity part of it, the fact that there's not alarms going off and things of that nature, we can't discount that that may have played a role in this, because as we know, patient concordance can be a challenge on negative pressure wound therapy. And so we believe that certainly had an impact on why these outcomes were the way they were as well. So, kind of based off of what Dr. Kirsner just said, the question really is are all things equal after all? So based on what you've heard, based on what's been described in a clinical study, it's really demonstrating that PICO has superior results, specifically in this study around DFUs and VLUs, which are challenging wounds to treat, as you all know. Oftentimes it takes months and much longer than that to manage some of these wound types. So again, I go back to those kind of three hypotheses of what's PICO doing different. And so kind of to summarize, ultimately, when you think about that concept of uninterrupted healing, meaning the PICO dressing doesn't have to be changed, it can go undisturbed as long as you're not using a wound filler. That wider zone of injury, so we're treating a much larger area, the wound, the margin, and the peri-wound area. We're delivering compression outside of the wound, which ultimately may benefit by decreasing edema. And we know when we decrease edema, we typically improve perfusion at the same time. And then lastly, the idea that this is an easier therapy for patients to live with. So the three of those areas are really what we're focused on to continue to understand why PICO is doing something different and why these results were superior to traditional negative pressure wound therapy. So with that, we'll close the presentation, and Dr. Kirsner and I would be happy to take any questions you may have.
Hi, Barb Seeger from Bayshore and Hamilton. I'm wondering if one of the factors could be the fact that there is no filler with the PICO. The surface of the wound is actually in a better state of moisture balance. The filler maybe dries that wound surface out too much. Has that been considered?
So I think that's a great question, and I don't think it has been considered, because typically when you think about negative pressure, whether it's traditional negative pressure or PICO, it's a closed system which should maintain a certain level of moisture balance anyway. But I think it's an interesting idea that really hasn't been, that to my knowledge hasn't been brought up as part of this work. So it's something I would be happy to suggest, but I don't know, when you consider that it's a closed system, you shouldn't necessarily be drying out wounds with negative pressure, even with a fairly dry wound. But there might be a subtle difference between the two that we just haven't recognized. So I think that's a great concept.
Because certainly the negative pressure that has the filler, that filler layer adheres to the surface more as well than the PICO does.
It does, and one of the things that I didn't get to this morning is they did look at the granulation tissue between the two different groups that were treated with PICO and traditional in the experimental study. And the trauma that occurred on the patients that had the foam, or the pigs rather, that had the foam, was significantly higher than the PICO-treated patients. There were also pieces of the foam, microscopic pieces of the foam that were left into the wound unintentionally, but they just kind of came off, which obviously increased the inflammatory effect as well.
Okay, thank you.
And I just wanted to add that what's very special about what we observed was twofold. The first, that it challenged our notions that what we preconceived idea of what may be going on, and also it was a way to take observations that we saw clinically and then take them back to the bench or back to the lab to really understand what's happening. And I think that's the continuing back and forth between the clinic and the laboratory is really how we advance ideas in wound care.
Just before the next questioner begins his question, I do want to respectfully warn you both, Dr. Kirsner and Kristi, that Dr. Gary Sibbald is considered the godfather of wound care in Canada. So go ahead.
No, Rob, I didn't want that introduction. I'm just wondering if you have any cost-effective data.
Yes. So there's a manuscript that's been submitted looking at cost effectiveness, and when you look at cost effectiveness, sometimes you have better efficacy and better cost. Sometimes you have better efficacy and worse cost. And sometimes you have neither. But in this case, just to summarize the data, is that the PICO dominated the traditional negative pressure. And what dominate means is that it was better clinical efficacy and lower costs. So that should be published in the next 6 months to show that this is not only an effective, efficacious, comparative efficacious, but also cost comparative efficacious data.
What about versus traditional healing methods?
So you mean not negative pressure? So that data we can only extrapolate, but the direct comparison was with the two study arms.
Dr. Kirsner, I have to commend you on handling Dr. Sibbald's questions. Usually most of us don't survive that experience so easily. In any case, I'd like to thank you, sir, Dr. Kirsner and Kristi, for your very scholarly review of negative pressure wound therapy, as well as to thank Smith and Nephew for the sponsorship of this particular segment of our program.